Welcome, everyone. Hi, I'm Lisa Reinhardt, and we're here today to talk about the logistics of reopening your practice. Before we get started, we have a couple of polling questions for you. So Monica is going to put those up, and then we will get started. Okay, please scroll down because there are several questions, and we need you to answer all of them before we can get the information.
Actually, I fixed it, Lisa.
Oh, perfect. One at a time.
Yes, so it's actually one at a time.
Yeah, that's okay. You need to highlight your answer and send it, and then we'll have the information for you so that we can share it with everybody. How are we doing, Monica? Are we
about 70%?
Okay, perfect. Thank you all for participating.
So it looks like it's slowing down. So I'm going to go ahead and end the polling for this one because we have a couple of questions.
Okay. Oh, this is wonderful. So it looks like the majority of our participants are nursings from the nursing part, but also some non-clinical staff, a few physicians, sales and marketing. Yay, we've got our mental health people in there. We need them at this time. And I'm sure some of the rest of you go all across the board of more essential people in our fertility practices. So welcome, everybody. All right, bear with us with a little bit of technical things. Okay, today we're going to be talking about the logistics of getting back to business. Oh, I'm sorry.
That's okay. There's another question I'm trying to find. Hold on one second, because I just want to
do that. I just want to make sure everybody's in the right place and we all know what we're going to talk about today. So let's answer a couple of questions before we go to that. One of them is about preparedness and how you feel about your center reopening. So let's answer this one and we can share it with the group.
Sorry for the confusion, but this is so much better than last time. We have 55% so far.
Okay.
Okay, it's about 70%, so I'm going to end it. It's going to be a true bell curve, I think.
Oh, good. People have started to think about it. That's wonderful. And looks like 15% of the people who answered say they're very prepared. So that's exciting. To those of you that are freaking out, please don't freak. We're going to try and give you some practical tips. And yeah, we all need another mental health talk. So that is always in the forefront of our minds. And we'll keep working toward that as well. Okay, number 3. Do we have a third one, Monica?
Yes.
Okay. I have checklists and protocols in place regarding the care of patients and staff during COVID-19. Absolutely, yes. I think so, but I'm not sure. I don't have these and would like some help obtaining them, or I don't have these but plan to make my own.
Okay, we're at 50%. Okay.
Oh, wow, that's great. And that's what we are trying to get to. We're trying to get to an even bigger curve of people that are absolutely prepared before they open the doors. For those of you that are a little bit on the lower end of the spectrum, don't worry. You have time. And this is how we're going to try and get you to start asking the right questions so that you can fill in the blanks.
Okay, last question for now.
I have checklists and protocols. Whoops.
Sorry, I keep going to the same one.
Okay. We currently have a consent form for patients to sign regarding COVID-19. So let us know yes, no, or I don't think we need one.
Okay, 50%.
Interesting distribution. Okay. So some of you have already made some movement in that area, others don't, and some aren't quite sure if this is something that they need. We're going to give you a little bit information about, more information about that, and maybe it'll help you decide which side of the fence you're going to be on. So let's talk today about some of our goals and what we hope to accomplish today. First and foremost, I think there's some basic rules we have to look at. First of all, none of us is an expert in managing the coronavirus pandemic. Truly, there is no one alive today who was an adult during a major pandemic in the United States. So we don't even have resources that perhaps we would have had in other situations. We certainly, your panelists today, don't sit here with all of the answers to many of these questions. And for many of you who may have listened to the COVID summit that Dr. Stephen Palter put on the other night, which was very, very nice, you can hear how much misinformation, no information, seeking information is out there among our medical community. What we do have to tell you is there's no magic reopen date. It's going to be different for everyone, and it's going to be based on your comfort level, geographic, a multitude of factors that Sue is going to talk a whole lot more about. But I think what we do need to look at is our strategies and how our strategies relate to who we're responsible to. First and foremost, we are responsible to our physicians. The physicians are the ones who are driving this medical care that we need to provide to our patients. So we need to, consider them as major stakeholders. Our second major stakeholder is our staff. We have to make sure that not only that our staff is ready, willing, and able to come back, but they can do it in as safe a manner as we can provide for them. And that takes some considerable thought and some planning to do that. Our patients, we always think about our patients. Our patients are going to be taking some risky steps, rightfully so, walking back into a medical practice. And how are we going to do that for them so that it actually is safer for them to do that? And I always like to add, what about the potential children we may be helping to create? They're not in front of us. We may not see them now, but they're certainly stakeholders in anything we're going to do going forward. Lastly, we need to think about our communities. When you're living in a pandemic, as all of us are learning, you're not living in it alone. We're living in it not only in the community of our practices, but in our broader community with regard to where we are situated geographically, the industries that are open or not open around us, and how not only our physicians, staff, and patients go out and utilize those other industries, but how those industries are going to react with us. So there are a lot of complexities that go into the logistics of getting back to business. So what are we going to look at today? Let me give you a quick overview. We're going to look at how to use this paused time that many of us are in to prepare for new ways, because things are never going to be the same again, and for safe ways to provide fertility care. We're going to look at what questions should we be asking before we open our doors and start seeing patients as we did in the past. We're going to give you hopefully some ideas for a reopening plan. But what we're not going to do are specific things that I also think you need to be aware of. We're not going to identify a specific start date. That is going to be different for everybody, and it needs to be an internal understanding based upon external information. We're not going to advocate that we all use the same plan. We don't all do things the same. We don't have any magic plan, just like we don't have a magic date. And so I think everyone's going to have to develop a plan that works best for their center. And the other thing we're not going to do is we're not here to criticize plans that are already in place or processes that other people are using. If it works for them, it works for them. So that said, I have the absolute pleasure of introducing someone who I am just honored, who thinks of me as a friend, as I think of her as a friend, and that's Sue Jasulaitis, who is the Director of Medical Affairs for Fertility Centers of Illinois here in my home state. So she's also a neighbor as well as a friend. Sue has a master's degree in nursing management. She also has a bachelor's in nursing and psychology. So we understand why Sue fills a multitude of roles and why she does it so well. But I think most importantly is she's passionate about fertility nursing. She's passionate about helping us have a much better focus on not only interacting with patients, but taking care of our staff, taking care of our physicians, and really making the fertility practice environment as safe and as positive as it can be. So with that, I say, Sue, thank you so much for being here. And I am going to take myself off video and turn it over to you.
Lisa, thank you so much. You can see now this video, I'm blushing, so unfortunately video shows all. But I want to thank everyone for taking the time out today to join us. It's so heartwarming to see all of the friends that we have across the country as well as across continents interested in this topic. We chose this topic based on concerns that the entire community has during this unprecedented time. And we did our best to come up with some common sense approaches to the new way to manage both our patients and our offices. But please, please understand, there are no silver bullets here. It really is a collection of thoughts and mechanisms for us to consider. Take this information and utilize it in a way that you feel best, but we're also very interested in hearing from you and how better we can manage this together. Next slide, please. So we know that the CDC has reminded us that women of reproductive age are often overlooked during a disaster. We know that resources and focus is always placed on the most critical patients affected, as well as the high-risk patients. But remember, we're here for our patients. We're here for you. We're here for our employees. We're here for society as a whole. And most importantly, the entire REI community will band together to take care of our patients. It's really important that we understand that we're all in this together and that we're doing the best that we can together during this time. Next slide. So the new treatment recommendations have been released from ASRM, and although it hasn't made any new recommendations to move forward, it has added some important language for us to consider. And this language is strongly recommending considering strategies for resuming treatment. Next slide, please. So what type of strategies are we going to start looking at when we're deciding whether or not to resume treatment, to continue pausing treatment, or what's best for us? Next slide, please. I think the important place to start is really looking internally at your centers and creating a COVID task force. This task force should be multidisciplinary. It should include everyone in your center that you feel has a voice in managing your practice, managing your patients, and managing your employees. And the goal for this task force is really, they're responsible for staying updated on every change, whether the industry changes or regulatory changes that will impact your decision to take care of your patients. And not only are they responsible for staying updated, but they're responsible for disseminating this information and educating not only their patients, but their employees. So through the course of this type of informal task force, you can establish best practices, clinic recommendations for your clinic that will be unique for other clinics as well. And advance, please. And understand that if you can't create a task force in your own center, join one. There's some great task forces available through ASRM, through the CDC, so there's lots of resources for us during this time. Next slide, please. But the main question is, what can we do now and what can we do in the future? So we started this concept of what we can do while we wait. And I think it's critical while we're waiting to keep our patients engaged. I think the vast majority of us are utilizing telemedicine to provide a safe and informative way to communicate with our patients. And the good news is the Family First Act is permitting reimbursements that are identical to new patient and inpatient consults. So that's revolutionary for us. It is critical for us to keep patients engaged so that not only can we plan for their next steps, but we can keep them informed of our practice plans, our individual practice plans regarding treatment. Next bullet. It's also important to utilize marketing efforts to continue patient contact. increasing presence on social media. I think we can all agree that our social media sites have more traffic now than they ever had, especially with shelter and home rules from most states. And whether we're communicating through patients with email or through portal messages would be beneficial, we need to make sure that we're constantly communicating with them. Many of us are doing a great job offering supportive services via our behavioral health outlets through webinars, and not only supportive services for our patients, but supportive services for our employees as well. It's critical also to keep your staff informed and engaged. We all know that as specialists, our staff are our most valuable asset. So keeping our staff up to date with the plans for our practice, as well as the information on how we'll reopen, is critical. And in addition to that, be aware of what your local competitors are doing. You won't really make a practice decision based on what your competitors are doing, but it will leverage your ability to answer your patients' questions and concerns. So we're all getting questions from our patients about, I see the other guy is doing this, and we're like, yeah, okay, we know, but this is what we're planning in our practice. So it is important to at least understand your local competition. While we wait, we can also maintain, and it's again critical, to a current COVID patient education piece on your website. And this should be updated as quickly as possible as new information comes out. I think that we all know that, and right now we're just halting treatment, or the recommendation is to halt treatment. But until the CDC or ACOG comes back and tells general patients to stop attempting pregnancy, our information to our patients is critical. So far they haven't said, don't try to get pregnant on your own. They've just said, let's not try to help them at this point. So giving that patient the updated information regarding their options for treatment, as well as risks for them and risks for their pregnancy, is critical. It's important to look at your patient population now. Decide what patients you're going to start engaging. Review your new patient or your treatment list. Some of it, for us, it's easier than others with our EMRs. Others, it's chart-based review, but find those patients that you want to consider as the first wave of starting. The best way to do this is go back through your recent new patient consults or follow-up treatment consults and see what patients are available or eligible to restart treatment. I think the best in the first line is the patients that we have placed on hold. So at the shutdown, what patients that couldn't resume treatment, those are the patients that you may consider looking at the closest. And really, now is the time to schedule those treatment consultations with those patients, especially utilizing telemedicine. Get them prepared so that when your center, at the point they decide to resume treatment, your patients will be ready. This will create a fast turnaround to get patients back into treatment and to continue the revenue stream that we're all looking at as we start patients. For insured states, you could consider obtaining insurance authorizations now. We do know that in Illinois, as a mandated state, our insurance providers have extended authorizations for those authorizations that were provided pre-COVID, and they've extended them through the end of the summer. So it is really important to know that if we start asking for authorizations now, we may be able to get patients into treatment much sooner. One more, please. And then, as Lisa will talk about, make sure that you have a COVID consent on file. As a risk manager, we could encourage you to consider the implications of starting treatment, the implications on your patients to obtain or to contract the COVID virus, and the implications of your employees. So having some form of informed consent is critical. And again, Lisa will do an exceptional job talking with you about those requirements. And then while we're waiting, some things to consider are these no contact procedures. Many centers are looking at options to test current embryos that are frozen for PGT, for either active patients or patients that may have produced pregnancies in the past, and allowing them to have this testing done during this pause period. Some centers are also utilizing this for egg thaws, egg thaw, embryo creation, maybe genetic testing, but refreezing these embryos to the point where a couple could go through treatment. I think we're seeing this in many centers in the third-party realm, to where preparing those patients for a future transfer. There are some centers that are looking at the option for home sperm testing, although I think that the efficacy of that test may be under question. Many centers are holding off and waiting to do that sperm testing in their own centers, but it's another option. And then, of course, utilizing the option for telemedicine. These types of no-contact procedures we can be doing now to keep patients and employees engaged. But I think before you can make a decision for your practice, you have to understand the infection timeline in order to better prepare your patients and better prepare your staff for what this timeline looks like. I really think it's important that we gear our practices based on the outbreak. This is a great slide from Dr. Juliana Kuzi that she presented at the iGenomics webinar late last week, and it really shows what this timeline looks at. And we know in looking at this, 85% of the patients that you'll see won't develop symptoms. So for the patients that don't develop symptoms, and you'll see that's about 30% of the overall population, their contagious period is about 14 days. For other patients that start to develop symptoms, the contagious period is extended from the beginning of their symptoms. So this concept that we only have to worry about 14 days is really challenged by this graph. And as we're looking at patients, we need to take this into consideration. We know that patients that will develop symptoms or employees that will develop symptoms traditionally will develop them within the first 5 days of exposure, and 98% of patients will develop them within the first 11 to 12 days. And clearly 99% within the first 14 days. So this graph is an excellent one to show you how the contagious period is really dependent on what symptoms this patient is showing. So this gives us a clear understanding of why pre-screening our patients and potentially our employees is critical to try to pick up symptomology to project when we can resume care or allow that employee to continue to work. Next slide, please. So it brings the point of OSHA. So all of us know OSHA requirements are in place, and they're less restrictive than they have been, but we really need to consider OSHA. Annual employee education is required, including PPE training. So please review during the downtime your policies and procedures and your training required to OSHA. If you haven't had an OSHA complaint, you may have one regarding appropriate PPE for your patients or your employees. So having this information up to date will be critical if you are in the position that you have to respond to some form of an OSHA complaint. Next slide, please. So it's also important to understand OSHA's position on PPE. So we all follow universal precautions, and that's appropriate during the COVID timeline. And I think that the biggest addition for universal precautions is really this concept of wearing a mask, right? We all know that N95 masks are the most protective, although not completely protective of the COVID virus, but they're impossible to source for our entire clinics. They're being reserved for, again, those high risk and at risk populations. So the type of PPE that you are required to wear is really dependent on the potential that your employees will be exposed to the COVID virus. Next slide, please. So it's important to understand that we don't take care of COVID patients, right? So full PPEs like shown here is not required to take care of our patients. I think we've all done our due diligence to understand that the best protection that we can provide is masks, both for our patients and our employees. And even OSHA will say to you, you can encourage your employees to purchase their own N95 masks. We've encouraged our employees, we've actually made masks for our employees. So whatever we can do to remain compliant with OSHA at this point is protective both of our patients, our employees, and our practice. Next slide, please. So OSHA has put out some guidance documents that I think are excellent. They really give you a step-by-step rules to follow on how to prepare your center, your patients, your employees to reduce the risk of exposure. So I would invite you to take a look at this document and really see how it applies to your center and ensure that you're following these steps. Next slide, please. And then once we've gotten to the point where we have realized this, we need to decide what's best for our practice. And as Lisa said, every practice has a decision that's based on what their needs are, what their patient needs are, and what their employee needs are. But I will say that it's not open for business as usual, right? We never will go back to in my opinion, the way that we were practicing medicine. It really will be a new reality for us. Next slide. So those of you that know me, I will say, well, hey, guess what, Zika, we miss you. One more point. Because you were easy compared to COVID. Like we were so focused on Zika for the last couple of years. And boy, I miss Zika at this point, right? So much easier. Next slide. So when we start looking at preparing, we have to decide who we're preparing for. ASRM has given us some interim guidelines for recommended categories, and they're really urgent and non-urgent. And how they define that are those urgent patients, treatment that is considered time sensitive. And really it's fairly limited to cancer patients, right? And maybe all other patients are considered non-urgent according to the ASRM guidelines. But I would say a new category is emerging, and that's a category that we all have to decide how to treat. And we're calling this the emergent category. And how we're defining this emergent category will direct us in how best to start forward. So we have to determine as a practice what patients we're willing to treat. One, if we're willing to treat patients, if we're ready to start diagnostic testing. And then once we've made that decision, who and when. So really, is it everybody back in the pool? Is it some people get to do treatment? As we know, some programs haven't stopped treatment. Some programs are restarting using all patients, and other programs are restarting using some patients. And how they're defining some patients is really depending on the needs of their program. I would say the majority of programs are deciding limited patients based on ovarian reserve and infertility diagnosis. And they're looking at this as their most at-risk patients within the fertility population. Next point. But what about for others, right? We do need to develop a plan for those patients that we're not willing to start. So not only are we developing a plan for the patients that we're moving forward with, but we need to have a tiered plan for those patients that may be next in line. So we're going to plan our steps based on what we know, and we only know what we know, and we don't know, obviously, what we don't know. And as Lisa said, we don't know all of these things. So it's okay that your plan changes on a daily or weekly basis, as long as you're applying the right metrics to your decisions. And timing is everything. Every practice will have a unique decision about when to resume treatment, if they're going to resume treatment. And many of this decision models are based on what's happening in your local area. It's really when this trajectory of cases have hit your area. I will say here in Chicago, the first projection was we're at the peak of our infections today, actually. So most centers are looking to resume some form of care after this peak has hit to decrease the exposure for both patients and employees. So your decision in your part of the country may be based on what cases. Clearly, New York is going to look much different than Colorado. So the teams that are helping to make these decisions are taking all of these things into consideration about when the timing is best for you. And then what do you do when you prepare for resuming care, right? We need to start focusing on how we're going to ramp back up. So we've put together some slides about ideas for best practices, and we purposely didn't say best practices because we haven't established them yet, but we've put together some ideas, and we started with staff. I think staff education is critical. Staff have to understand what this virus means for our patients, for their treatment, and for our employees, and keeping them informed is critical. Many centers are looking at their patient population to identify their at-risk individuals and offering those individuals furloughs if they're higher at risk for comorbidity or age during this time. Many centers are offering furloughs to those patients, or excuse me, those employees that don't want to work. Some of our employees are afraid. They're afraid to come to work, and we're giving them the option to go ahead and go on furlough. I think some of the techniques that we've used and heard other centers is really establishing these team schedules. The whole goal is to minimize exposure, so staggering your teams. If they're in an event of exposure, that will only be exposed to one team. So really reducing this idea of cross contacts with your teams is critical. And again, most centers have established some work at home possibilities, which really reduces the potential for the spread of this infection. Some centers are screening employees prior to the workday, which is appropriate, and really considering more separation and isolation procedures while employees are working. So the day is gone where we all get to sit in the lunchroom together and have lunch. You know, we're really separating our staff, a desk between them or whatever that may be, right? So when your employees are actually working in the office, you need to make sure that you're separating them. It behooves us to come up with some back to work guidelines for our employees that may have been exposed or at risk, and there's many guidelines to follow for that. But a simple reminder to employees to every day wear clean clothes. I know it sounds silly, but every day you come in to wear clean clothes to work, especially for the employees wearing scrubs. So I apologize, this is a busy slide, but we wanted to talk about some best practice ideas for patients. And again, I can't say education enough. We've talked about the classifications of patients and how you're going to stratify your ramp back up based on the decisions your practice is making. But based on the trajectory of the illness, I think, again, pre-screening is critical. Most centers are pre-screening their patients, and here's some examples of how the pre-screening should be done. But if a patient fails the screening process, they should be rescheduled. They should not be allowed in your inner sanctum to have a higher potential to infect your staff or other patients. We all know that PPE and hand washing is critical. This social spacing is going to be our new norm. The whole concept of this is to empty your waiting rooms. Do not allow patients or employees to congregate. Keep those employees and patients away from each other. At FCI, we're not permitting patient walk-ins. So if you don't have a scheduled appointment, we will schedule one for you. And then we're really rethinking what we mean by non-essential testing, and not every test result has to be done the same day. So we can triage our patients based on who has to be taken care of that day and who can be pushed. And like everyone, we're restricting visitors. So some ideas for best practices for patients include some of these and many, many more that I'm sure your clinics are instituting. But I think it's critical to look at your patient flow, and how your patients go through your organization is unique to your center. We really do need to limit that patient flow to what patients our centers can manage safely. Some of our practices have multiple locations. Some of those locations are larger than others, so the plan for one location may be different for the other. But I do like some of these concepts, like this Costco style care. Maybe a larger center can manage 10 patients at a time, and the 11th patient can't come in until the first patient leaves, right? And I think most of us are instituting this drive-in care concept, where patients will literally wait in their car until it's their turn to come in. And that way we're limiting the number of people in our offices. Not only limiting them, but also recreating appointment calendars that allow us to stagger these appointments. We only have so much volume, so we have to understand what volume we can absorb to stagger these appointments accordingly. And one thought is really this concept of instituting one-way traffic patterns for your patients. So the next slide will focus on what we mean by one-way traffic patterns. So it's important to have one point of entry for patients and for employees. This way, this point of entry can be monitored, and with the goal of moving patients around the clinic as little as possible. We want to make sure we're exposing the patient to a few people as possible. So one of the examples would be for centers that have two separate check-in, check-out desks, really have that patient be a one-stop patient. When the patient checks in, have them take care of their billing process, everything at that point, make it follow-up appointment, whatever it may be, and then go on through their point of care. From there, as much as you can, combine patient tasks. Bring your employees to the patients and not your patients to the employees. So for instance, blood and ultrasound, our monitoring patients need that every day. So perform your phlebotomy services inside that ultrasound room, and then the scan after that. Once that's done, your patient's checked in, your patient has checked out, they've paid their bill, they can leave. So they're leaving in the same flow, one-way traffic, not moving patients around multiple areas in your office. For any patients that have follow-up questions or concerns, we're managing that through phone or portal messaging, and again, e-signing for consents. So if at this point your centers don't have the capacity for e-signing, you will see higher patient traffics in your office, because the ability to find a notary at this point is impossible. So to limit your patient contacts, e-signing is something that your center should be considering. And then just some basic social spacing. For a waiting room, we've placed signs between the chairs that say, don't sit here, right? And so sit every other seat, or some centers are removing those middle seats. This concept of marking your centers for the 6-foot rule is very, very appropriate. It's a visual reminder for patients and staff that this is what 6 feet means, and they're really adhering to that 6-foot guideline. So some of the things that we're doing in our offices, including taping the floor for 6 foot, and this intermittent seating area is critical. And again, the entire goal is to get patients in and out as quickly as possible. So let's talk about other areas. What about best practices for IVF labs? Well, we do know, luckily, that there's no clear impact of the COVID virus on our embryology labs. Although testing is continuing to be updated, there's been no evidence that shows that the lab is affected by the COVID virus. There has been new sperm guidelines instituted from CAP and CLIA that really involve limiting the possibility of airborne droplets during sperm processing. So this idea of centrifuging sperm, some additional layers are required for sperm processing to be compliant with the regulatory bodies. And that really includes more PPE, or the suggestion is to use a laminar flow hood when you're processing sperm, which isn't realistic for most centers, but really providing an extra layer of protection from the sperm to the technician. And then most centers have instituted this no patient contact rule for embryology staff. I think that that's critical, and as we look at the next point, this concept of the embryology staff being your most essential employee. Now, I would say this is probably a controversial statement, that your embryology and staff, in addition to your physicians, are your most essential employees. But I will say that although I think I'm an essential employee with my company, I still don't know how to do ICSI. So the skill sets that are required for a small group of people, we need to do better protection measures to keep them healthy. And that would include alternating teams, right? You cannot have one exposure take out your entire IVF lab, or no one can do a retrieval, right? And then also this concept of quarantine tanks. Many centers at the beginning of this has stored sperm, eggs, and embryos in separate tanks so that we can say, as of this date, here's all of the samples that have been sequestered. Although we don't think that this will provide a problem in the future, we are able to say that we have not mixed COVID patients' samples with non-COVID patient samples. And then I think we're all pretty well versed with the ideas for best practices regarding our environment. And it's really clean early, often, and in between patients. Many of our centers pride ourselves on patient contact. So we don't have barriers at the reception site. We don't have those things, but this may be a requirement for us in the future. Right now, we're double bearing mask for the patient, mask for the practitioner, and at this point, that's okay for us, but we may see in a short order that we would be required to put some physical barriers at check-in, check-out, and some procedure areas. But this whole thing is designed to limit these access points for patients and for employees. Next slide, please. And what about your IVF service area? Like with embryology, the IVF service area is one of those critical places. So we really put together some thoughtful suggestions for your IVF service area. This is where it's critical to screen your patients, right? Because when your patient walks in for their retrieval, we don't know that they have been exposed or positive to the COVID virus. We may not know for a week from then. So a week from then, the patient calls us and tells us they've tested positive. Now we have to go back and look to see who it is they've had contact with and then quarantine appropriately. So the best that we can do to pre-screen these patients when they walk in will really benefit us in the future. So some of the suggestions is really not to allow your patients back into the inner sanctum unless they're as clean as possible, right? So have your patients change their clothes outside of your treatment area. Have their clothes bagged up, and then once they're in your gown, get them back into your procedure area. This should include employees. So many of our centers have our locker rooms inside the treatment area, but really looking at having employees change their clothes outside of this area will keep this environment clean for you. We know that the coronavirus can live on clothes anywhere from 2 to 24 hours, so this isn't something that we should be taking lightly. Again, many of us have already instituted no partners or visitors during the treatment area. Sperm drop-offs only, common sense. The less we can limit contact with patients, the better. And really coming up with a new way to space our procedures. You know, we'll go from procedures every 15 minutes to, in some centers, procedures every 45 minutes. So your ability to manage procedures really will dictate who and which patients and how many patients you can see as you're beginning to ramp up. One of the other important things to remember is in your procedure areas, let's go back to one-to-one nurse-patient contact, right? One nurse should be admitting your patient, one nurse should be taking care of them, and one nurse should be discharging them. And again, if you see a post-procedure exposure, this will limit the contagious employee count that you may have following that. Right now, some centers are looking at better ways to manage anesthesia cases, whether we're adding OR shields or whether we're coming up with a way to keep a patient's face covered during a MAC anesthesia. So really some form of protection during the OR procedures itself is critical for you guys to think of as well. And then inventory management. Many of us are limited in our ability to take care of patients because of a supply issue. Really taking a look at your inventory to see what you have. Do you have enough supplies to take care of patients, and can you get more? If you can't get supplies, you can't take care of patients, right? So PPE is critical. Take an inventory of what you have and monitor your inventory. I think that we've all experienced theft with our masks and our hand washing, our hand sanitizers. So really secure the PPE that you have in order for you to be able to take care of patients. Order as much and as frequently as you can, and really look for those non-traditional sources. I will tell you, one of our IVF coordinators is amazing. She stops at the gas station and she picks up cleaning supplies at the gas station. I mean, it's just crazy where she's able to find cleaning supplies. But really, your ability to manage your supply inventory is going to dictate how many patients that you can take care of and how long you can take care of them. And I would really encourage you to leverage your suppliers. All of us have great relationships with our suppliers, and sometimes, you know, making sure that you're a preferred center for your supplier is important. But also be creative. Determine what exactly you need. We don't need full PPE, right? We need gloves, we need hand sanitizer, we need masks, right? Determine what you need and determine how you're going to get it, how you're going to maintain those supplies. And can you improvise? I know there are some centers that are having difficulty sourcing cleaning supplies, so they're making diluted bleach to clean their centers with. So just being creative, making sure that if you're going to restart treatment, you can do it in a safe fashion. And can you come up with non-traditional ways to find PPE to keep your staff protected? And then this concept of considering COVID testing. I think this is also going to be our new norm, and this is another great slide from Dr. Kuzi from the iGenomics webinar. It really shows the testing that right now is available. We know that the gold standard at this point is this real-time PCR. It's the one that has emergency approval from the FDA. But please understand that this is a yes or no test, right? It says your patient's positive or they're not, right? They could get infected 2 days later, right? So where our industry will be moving is this concept of antibody testing. So the ability to test someone to say they're actively infected or they've created an immunity, either from active infection or hopefully within a year from vaccine. So although there's controversy whether these rapid tests, these antigen tests are ready for prime time, they are on the horizon for us to be able to test patients, test employees to determine who's infected and who's immune to the virus. And a note on testing. If your center is considering testing all patients, the question is when, right? When should you test them? There's a few schools of thought, testing patients at the beginning of their cycle, allowing that 2 to 4 day time frame to get that test back. Some centers are testing them immediately before their procedure, whether it's retrieval, frozen transfer, insemination. But if your center is choosing to test patients, please be aware that according to the CDC, there are additional PPE guidelines for the employees doing the testing. And really it talks about more PPE. It really talks about more of a face shield if your employees are choosing to test your patients. So please be aware that there's additional safeguards if you're testing your patients yourself. So in summary, we tried to create a brief overview that this is a new day, and this new day brings a new reality. We are all challenged with a new way to provide patient care under these circumstances, and this new way to provide patient care will be with us for the next 6, 9, 10 months until we can create this curve where most of our patients and employees have become immune. So once we start to see this immunity, remember that it's okay to treat a patient that's immune, right? It's only patients that are not exposed or are infected that are subject to these treatment restrictions. So hopefully with new testing guidelines, with new treatment guidelines, we can start to see this curve move towards going away from limiting testing or limiting care to critical patients and including care for patients of reproductive age.
Excuse me, Sue, two quick questions that were emailed to me directly. One is the processing sperm. I guess there was a question. Could you provide us at some point with that reference, and I'll email it out to everybody?
Absolutely.
And what type of thermometer? Is there a certain type of thermometer that is necessary to be used? Is an oral okay, but the people are wearing masks? Is the ear thermometer okay? Do we want to do rectal? No, I'm just kidding. But
Yeah, well,
is there
no.
a certain type of thermometer that is recommended?
I think that's a great question, and I can share what our individual challenges have been. I think the best thermometer is a no-touch thermometer, whether it's a temporal thermometer or an ear thermometer. The challenges that your centers will have, if you're using oral thermometers, which are available in your centers, you're going to be using up more PPE to take care of that patient. So our staff found that they would need to change their gloves after every patient contact because they're using an oral thermometer, and that's really the respiratory route. So we've moved to temporal thermometers, which are incredibly hard to source. The ones that are non-commercial break very easily. So I would encourage you to order as much supplies as you can. We started off with 9 thermometers for 9 offices, and we're down to 3 temporal thermometers. So they're not intended for large scale use, but that would be the best recommendation for anything that you can do that is no touch for your patients.
Thank you. And just for everybody that's saying great presentation, of course, Sue, we still have a couple of slides that Lisa's going to present on informed consents if you guys have more time to wait for that. But and the final thing I'm going to say is if with the speaker's permission, Sue and Lisa, I will send you a link to these slides or send these slides with permission as an attachment. I had about 15 probably to 20 requests for that. So thank you so much. And if you guys want to stay on, Lisa's going to talk for a couple of minutes, and then we hope to have an interactive question and answer session, but I think the informed consent part is pretty important.
Thank you, Monica. And Sue, thank you so much for that. That was just amazing thoughts from somebody who's on the front lines and working to help their practice get back together. I'm going to take some time to talk about one piece of getting prepared, and that's your paperwork. I'm not going to spend lots of time on liability because our talk today is how do we take care of our patients. I'm not as much concerned, even though I'm a risk manager, on everybody being concerned about, am I going to be liable? But I know those questions are out there. One of the questions is a fertility nurse going to be liable if a patient gets COVID while they're in the office? And are you covered under your practice's medical malpractice insurance? I will tell you the insurance piece of it, obviously I can't answer that without looking at specific policies, but in general, employees of any type of business, including a medical practice, would be covered under an insurance policy as long as they are following the policies and procedures of the practice and they don't do anything that is negligent in and of itself, or they do something that's willful and reckless. Those are a lot of legal buzzwords, but something to think about. Could a patient bring a claim against you if they think they got the virus from you? The answer is always yes. Patients can bring claims for a lot of different things. However, there's a very, very difficult hurdle they have to get over, and that's the connection between you and them as to how they got COVID-19. We know that this is, as some doctors are saying, a crazy contagious virus. And so that's going to be a huge, huge hurdle to get over. And while I'm not going to say it can't happen, I will tell you that I do think the chances of anybody actually winning on those types of claims is going to be very, very difficult. So hopefully that helps you a little bit. Do I think our practices are going to change? Absolutely. And I think informed consent is an area where we're going to see some changes. I just wanted to give you a slide with a quick review that talks about the 3 different pieces, if you will, of informed consent. One is the patient, and that's where they're at. Are they competent, and are they doing this and giving you consent to be treated in a COVID environment voluntarily? Then we've got the provider side and the essential elements of what you need to be telling your patients about not only their diagnosis and why you're treating them, the test, but the risks and benefits, which now has a whole new pod around COVID-19. And then there's the agreement the agreement between the provider and the patient that they understand it and that they have the autonomy and they are making the decision to go forward. But COVID-19 is bringing us some really big challenges. As Sue said, and as I have said in previous talks, we don't know what we don't know. And we're learning as we go along. We also have to look at, and part of this goes to another question that I had is, if fertility centers are essential, how do we determine that they're essential and move forward? That's looking at the risks and benefits of doing our treatment now. So it's a time-sensitive issue. Is this the time to be doing this treatment, or is there a safer time to do the treatment? And again, needs to be determined between the provider and the patient. We have to be transparent, but we're being transparent with a moving target. This is a fluid situation. I look back to what I thought about COVID-19 on March the 10th and how I feel about it today on April 16th. Things have changed dramatically. Any document, policy and procedure, consent form that I may have put in place on the 10th of March is very, very different now. And so we need documents that are timely, that are informative, but that also help protect everybody. So one question that comes up and that has been raised in other settings is who should be getting informed consent? Most jurisdictions say that this is something, a process, a dialogue that happens between the treating physician and the patients. Pre-COVID-19, most of us were using physician extenders to actually obtain the obvious yes or no from the patient and getting their signature on documents. Now, just a little caveat from a risk manager and a lawyer. The signature on the document is not the consent. The consent is actually the discussion between the treating physician and the patient saying yes. But in a court, the consent is going to be evidence. That form is going to be evidence that you actually got consent. However, even before COVID, some courts were moving away from that and saying that you can't delegate this. And a 2017 case brought this out and told a surgeon, no, you were the one who should have talked to the patient. You were the one who should have gotten their signature on the form. Let's take that in consideration with ASRM guidelines. ASRM recent recommendations have said that it's key that physicians make decisions in consultation with their patients. And this is something that some physicians are looking at to say, not only does that make opening, reopening, or what type of treatment we do back on our shoulders, but it kind of opens the door to maybe we should be the ones talking to our patients about this. And so I say, as Sue did, we're in a very unique situation. This is a pandemic. We've never lived through it before. And I think we need to look at some closer communication between our doctors and our patients. Consider making your treating physician the responsible person. And I know that will be difficult in larger centers, but maybe we do some sort of video, something that will give us that closer connection. And again, as I always say, document, 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 to help support what we did. So what do we consider in drafting your consent forms? Well, I always say you have to tell patients not only what you know, but what you don't know. I like to have background information on whatever either procedure, whatever virus, whatever threat is out there. When we did consents for Zika, we explained Zika. So I think we do need to explain what we know about COVID-19. What's the effects on gametes? What's the impact on pregnancy? And here I like to highlight, we don't know very much information on early pregnancy. The data that we have is out of Wuhan, China, and it's out of a retrospective study that was done in 2 affiliated hospitals in New York. But those were only with less than 100 patients combined, and it only really talked about patients who presented with COVID-19 in the 2nd and 3rd trimester. So we still really don't know what's going to happen with early pregnancy. You have to talk about specific risks to your patient. We know that COVID-19 can be a riskier situations for patients who are immunocompromised, for patients who are diabetic, for patients with hypertension or cardiac disease. And we also know from studies of previous pandemics that pregnant patients may be at greater risks because of the physiologic and immunologic changes of pregnancy. We also need to let them know the current recommendations from professional organizations. I don't think it's fair to give them all of this other information and then, not tell them what ASRM is saying, what the European group is saying, what the CDC, what the WHO are saying. We also need to let them know what our treatments are going to be. In other words, what are we willing to do right now, and what we're going to exclude or what we're going to postpone to a later date when we have more information. Hopefully, you're not even going to be presenting any type of a form to a patient that you're not going to treat, because the whole idea of explaining all of this is to get their acceptance to treatment. How are you going to handle canceling cycles and that possibility, and why would you cancel cycles? If we're going to be doing screening of our patients and we are doing temperatures and pulse ox readings, and the patient comes in and they've got a temperature of 100.4 and their pulse ox is reading at 92%, we are probably going to have policies and procedures. And in some places, they're going to say, nope, you can't even come in the door. Your cycle is canceled. And you truly need to, be monitored for exposure to COVID-19. That would need to be explained to the patient. Not only what happens on the medical side of that, but for some centers that feel comfortable with it, also what happens on the financial side. And explaining what monies are kept, what monies are paid back when you may be canceling cycles in the middle could be key to how you might be able to collect money later on from that patient. And then finally, you have to get a specific agreement from the patient that they are willing to continue treatment during the COVID-19 pandemic. Now, across the bottom of my screen, I have an email where you can get some sample text for this. And I do have a sample form, but I caution everyone. Consent forms may not be appropriate for every single clinic. It needs to be reviewed by your physicians and your legal counsel, and it may not be appropriate for the jurisdiction that you're in. Certain states have different laws about informed consents, and you have to be very, very careful that you make sure you follow all of your state laws. But I believe in sharing, which is why I'm here, which is why Sue's here, and I like to give people something of a base for which to start, because I don't believe in recreating the wheel. And Sue and I are on the same page with that. A lot of good information out there. Use what you can and build on it to make it work for you. Just a couple thoughts on your SOPs. Again, don't reinvent the wheel. If you have a current disaster plan, please use it. You put a lot of thought, a lot of work into it. Add a brand new section about viruses. I don't even know that I would necessarily call it COVID-19, because when we look at what's going on in our world, we're going to have another attack, if you will, from a virus. We're going to have another pandemic because we're getting antibiotic-resistant bacteria. We need to know how to deal with it in the future. Look to all of the professional organizations for their guidelines and make it work for you. Make it specific to your center. But then I caution you, please, please, please don't do what a lot of us do with the hard work we put on paper or on our computer and put it on a shelf and it gathers dust. Make them living policies. Use them to educate your staff and your patients and update them. This is a fluid situation. That policy should be on your desk, on your computer, every week as we hear something that we actually make changes to make it work for us. And then the other side of your SOPs is, SOPs are no good if you train everybody, if you put them in place, but you don't monitor that there's compliance. And I certainly don't advocate being, the police in any of your practices and having all kinds of penalties, but you do have to have a method of making sure that we are keeping all of our stakeholders safe as we move forward and reopen. One of the things I like to think about is how to turn really tough situations into opportunities. And I think all of us are feeling, and you fill in the blank. We're angry, we're sad, we're fearful, we're scared, we don't know what to do next. But I think as long as we utilize all of the collective information that we have, and we try and pull away from thinking about what pressure this has put on our ability to practice medicine, on our ability to work, to play, and to do all the things we want to do, we can probably move forward and not only get through this, but maybe make this a better way to practice medicine and to provide not only a safe environment for our staff, but better care to our patients. So thank you very, very much for all of that. Monica, I think you have another poll question, do you?
Just one more.
Okay.
Okay. Oops. Hold on a second.
Okay, for those of you that are still there, let us know. Would you like there to be a Facebook page for Fertility Nurse News that can be used as an online forum or way to connect with others?
Lisa, while we're waiting for this, I sort of reduced how important you are just because you're one of the organizers of this. Can you just tell us quickly what you do and what your job is, since I didn't really adequately introduce you?
Thanks, and I certainly I'm honored to be one of the organizers. So, but I am a nurse attorney who has been working in the field of fertility for the past 30 years. I did do some corporate transactional law in the middle of all of that, and then went back to being a practice developer, manager, etc. Now I do risk management. I do a lot of policies and procedures, informed consent, which is one of my pet projects, so that I can help fertility centers and other medical practices provide the best care and avoid some of the pitfalls. I hate lawyers, just like a lot of you do. And I can say it openly because I am one, but I have realized, and I've been in a special position to be able to be a bridge between law and medicine. And I think right now is a perfect time for all of us, cross that bridge with your corporate attorneys, let them help you and you help them so that we can know when it's time to open and we can have the right materials in place to protect everybody. So Monica, thanks for that.
So I will jump in and say, for those of you that may not know Lisa, and I imagine it's a very small percentage, she is an amazing wealth of information. The passion she has for our industry and the dedication that she has is amazing. She is so helpful if you have questions, issues, or concerns regarding this or other practice management questions. So thank you, Lisa, for organizing this, as well as Monica, and allowing us the forum to tap your infinite knowledge on the subject. We appreciate it so much.
I thank you. I thank you. And people feel free to contact me. You have my email address and you'll get it again. So it looks like we have an overwhelming consensus from those of you that you want some sort of online forum. We will look into the, pros and cons of Facebook and other forums and see what we can do about that. Monica's our technology guru. She's amazing. So we'll work together on that.
So
okay.
We have a couple questions. We had a couple questions for the two of you. One is ultrasound. Obviously, you can't maintain 6 feet distance unless you have an ultrasound machine that we don't know about to comply with that. So what do we do in terms of ultrasound?
I think the ultrasound is a unique population because they have a lot of contact. Just like at retrieval, they have a lot of contact with the patients and it's more prolonged. I think the best thing that we can do at this point is ensure that our ultrasonographers are as protected as possible. Our patients have to wear a mask, and our ultrasonographers have to wear a mask. If you have the ability for N95 masks, that's one of the group that you could consider. If you don't have the ability for N95 masks, please encourage your sonographers to purchase them. They're available, they're just not available in large scale. So it's hard for a company or an employer to say, please go out and purchase your own protection. But if we could purchase it, we would for you. So the best that we can say for your sonographers is that we're doing the best we can to screen the patients and present the lowest risk patient possible. And that's a good point. Remember that our patients want to stay healthy too. So from a population standpoint, they're probably the lowest risk that we'll see. They want to get pregnant. They don't want to transmit this to their baby. They want to continue treatment. So ultrasound is a tough one, and I wish we had a great answer. But the best answer that I can tell you is in and out as fast as possible. Take care of yourself. Make sure that you're healthy. Wear a mask. The patient has to have a mask. Don't bring any outside visitors or children to OB ultrasounds. Limit the contact as best that you can. And if you have more protective supplies, that's one of, including your OR, that's one of the groups that you should consider them for.
If I can just tag on to that, Sue, which was everything that I would have said and more. As usual, you do that. Let me just add, you need to be, I go back to the be creative. I think this is a time to look at all of our functioning. So stand in the doorway of your ultrasound room. Can we move equipment around, move tables around so that the patient and the sonographer don't have to face each other during the scan? I mean, I know it sounds kind of crazy, but I also do ultrasounds. And I think you can think of a little bit more creative ways so that you're not having face-to-face contact. Also, the patient gets in the room and gets ready before the ultrasonographer's in there, you know, so that you minimize contact. So in those kinds of ways, you know, I really advocate walk through your practice, kind of walk through what your procedures look like and make just a few little changes that could make a big difference.
I think that's critical, Lisa. Thank you for some practical things. And as well, just to jump in on that, is enter your reports after you're done scanning the patient. So once the patient leaves the room and you're preparing to clean for the next patient, that's the time when you're in the room by yourself that you're able to enter those reports. You don't have to do it in the room while the patient's changing. Get the patient in and out, little contact as possible. And, you know, we're all interested in providing the best care as possible. And let me tell you, not just your employees will appreciate it, but your patients will too. It's a great question.
Should we have a return to work policy after COVID testing?
Absolutely. We have a return to work policy in place. If an employee has had a suspected, or luckily we've not had any employees that have had COVID, but if an employee has had a suspected exposure, we require them to have medical clearance before they come back to work. So we require the quarantine period depending on when their symptoms started, and we require them to have medical clearance. Now, at some point, we hope to be able to adopt this antibody testing so that we could offer some testing through an employee health system to be able to confirm that the patient or the employee is actually negative before they return to work. Great question. And I would encourage all centers to have this type of policy in place.
I got a few questions about how patients are going to fall in queue, so to speak. So how do you keep track of patients on hold? Or that come through telemedicine, some places that are not doing diagnostic testing, and the holdup is the saline sonogram. Where do they fall in the queue? What are other centers doing? If you guys want to put in the chat as well, but what are the recommendations? What seems fair?
Well, I think the best thing is look at your own practice to see what you've done in the last 2, 3, 4, 6 months, right? We know that it takes a patient 2 to 3 months to be able to be eligible for IVF care. So the consults that you did 2 or 3 months ago are the patients that will be the potential first population of patients that are eligible for treatment. So it's very labor intensive to go through your past patients, but it's very fruitful to find those patients that you want to treat. And I will tell you, your nursing staff, Your physicians, they know what patients that are waiting. Those are the patients that are calling them constantly, right? So they have made their own lists. So ask your nurses, who do you have that's ready for treatment? And, it's really critical that when you're talking with patients, especially if you're limiting the type of patient that's coming back for treatment, that in those insurance states, you have to really send a disclaimer that says, yes, you're eligible for treatment, but we still need insurance authorization to proceed. So even if you're selecting a specific type of patient to resume care, and not all of your patients will be able to start care at the same time, nor will they all be eligible to start care. So you have to come up with, again, a mechanism in your center. How many patients can you start at a time? If you're a center with a very large volume, that will be a percentage of your patients. So you really need to do due diligence within your practice to determine what your volume can hold. And again, I urge you, take a look at what your supplies are on hand. You could open your doors today and do 1,000 retrievals this month, but you may only have supplies for 200. So that's going to dictate what patient flow can happen in your office.
A second most common question seems to be, there are certain things that are just patient-facing or patient-staff interactions that you really can't, or be very difficult to compromise in terms of that face-to-face interaction. So for some people who are doing face-to-face injection teaches, other times it's, the patient starting a treatment cycle, the very first start of the treatment cycle. Is there a way that the staff can either get specific training available for patient-facing staff interactions in regards to PPE or policy and procedures? Do you have something like this in place, or what are your actionable items or suggestions?
Sue, let me just answer that a little. I'm going to answer the general piece of that. I think the majority of practices across the country have paused to some extent. And so you may have staff that are on furlough or are working from home, et cetera. I think this is a perfect time to start looking at changing the way we do things. And I say that knowing I'm going to get a lot of, I can't change. I had the same discussion with my daughter who has her own law firm and had to meet clients and said, we can't change. I think we need to take those hard sit downs, thought processes of how we may want to change. I don't know about the rest of you, but my husband is a reproductive endocrinologist, and he has transferred many of his patients to telemedicine, and it works. It's going very, very well. There are a lot of platforms to do this with your patients that are HIPAA compliant, that are not very expensive. And so I think instead of, trying to say, how can we do this and be safe, or how can we do this and have the patient sign away their life and their 3 children we're going to give them so that they don't sue us for doing it the way we always did. I think we need to take long, hard looks at, is there another way to do this so that we're not exposing either staff or patients to prolonged contact, which in most cases is face-to-face contact within 6 feet, 15 minutes or longer. Sue, you want to add to that?
Thank you, Lisa. I agree 100%. And I think the decision tree has to be, is this a critical encounter? I would challenge anyone to say, and a one-on-one injection teach is not a critical encounter. We have many, many resources from our pharmaceutical companies to our pharmacies that supply us expertly with medications for training videos. Zoom consults can be used for nursing consults as well. So I think every time you look at what your practice is doing, in the back of your head, say, am I willing to contract the coronavirus by continuing this procedure? And if I am, how can I make myself as safe as possible? There's some things that we have to touch our patients for, right? But there's many, many things that we can come up with a new way. And that's what this is all about. What can we share? What new ways can we share? And can we incorporate them into our current practice?
I also just want to add that there's some really good short articles out there, which I'm also happy to include in the email, about how to make Zoom as close as possible to an interaction, which, not that you can tell from my behavior today, but not looking at the side.
You're right.
Yeah, and showing your hands when you do stuff. If you're doing injection teach, right? So you don't want to keep your hands down here, but just to make it more familiar, how you start off the first couple things that you say and do. So I'm happy to also share links to that. In fact, I'm just going to do it, and you guys could decide not to read it, so you don't need to write in the chat.
Perfect.
But really, that's the other thing you can be doing right now is honing your tele skills, your visual skills, and maybe we'll end up having a talk about that, a short one. But I'll send you some quick articles.
And I don't want to minimize that this is going to be hard. I know it's going to be hard, but as you know, staff that I've been manager for over the years knows one of my favorite sayings is sometimes the harder thing to do is the right thing to do. And we need to keep that in mind as we start to look at how can we practice with a pandemic that's not going away anytime soon.
Listen, when we are grateful for Zika virus, when Sue said that, I think that is the first time I've ever heard anyone say that. So another most common question has to do with travel. Is there a travel policy? A non-clinical person said to me, I have patients traveling for treatment. We see several patients that come from over the US, and we are currently debating if they should and whether they should be allowed to come in and when to ramp up. I want to hear on the clinical side, in terms of current policies, would they be applied to everyone? I don't like the idea of discriminating people based on their geographic location. And then is there a travel policy for staff? Can they not go to one of the cities that seems to be more inundated with this if you live in a city that doesn't seem to be?
I would steer away from more policies than practices, right? And standards. We've all encountered these types of questions, and we answer them anecdotally on a case-by-case basis. So if we have, as other practices, been presented from couples or patients that have come from at-risk areas, and what our recommendation has been is to remain in a safe location. For instance, if you're coming to Chicago from China, remain in Chicago for 2 weeks to determine that you're not affected before that we would allow you to then initiate care. And remember, during that quarantine time, you can do your telemedicine and your preparations for that patient. So we have also applied that same logic to our employees. For our employees that have chosen electively to travel to areas that are either at risk or pseudo risk, we have required them to home quarantine for 14 days before they're eligible to come back to work. Now, for home quarantine for travel, we haven't required medical clearance unless they're symptomatic, but we have required them to home quarantine before we'll allow them to come back to work.
And I would also encourage you to keep abreast of what the state, local, and federal guidelines are with regard to travel, because there are still some travel restrictions in place. And so you're going to need to be aware of how those apply to your patient population. If you have a large patient population that's coming internationally, it may be a little bit more difficult. And I will tell you, here in the Midwest, there have been some concerns about states stopping transportation between states. And I know also in the Northeast, they've been talking about it. So just be aware that there may be some regulatory things that you need to look at with regard to that.
A suggestion from Griffin Jones, who's an excellent marketer and a good friend.
Hi, Griffin.
Griffin, although he made fun of my lack of technical skills, is that if you are doing these things, you should document them on social media, because your patients are looking at social media. Here's my hands. Your patients are looking at social media, and it can reassure them that you not only are taking this seriously, but first of all, here's the first idea that things are going to be different when you come in this time, and that we're doing it for you and to reassure you, and that there's a lot of iterations of this as we go along. So as that changes on social media, that can be reflective of what's going on in your center, so that people realize like what's happening today might not even be happening the day after.
And Griffin, I think that's key. We have to keep educating not only our staff, which includes physicians, okay, but also the patients. And again, I say this is fluid. This is going to change more frequently than we want to, because it means, yes, you have to, rewrite, re-educate, et cetera. So thanks for that, Griffin. I appreciate it.
I have another question here for Sue, and this is actually might lead to one of the other talks that we're planning, because there's a whole third-party nuance and complexities to this, but I'll pose it to the group. In reviewing the recommended categories and prioritizing which patients to schedule first once the clinics start performing procedures, should we assume that patients utilizing donors or surrogates would have difficulty getting their donor or surrogate scheduled quickly? This would be an important expectation to set for these patients from a surrogate ED agency perspective. And these are also the people that may need the saline sonogram done before, and they live in some other state that's not doing it, before they can get a donor profile, before they can move on to the next steps. They already feel like they have these seemingly difficult barriers in place.
Well, I can't provide you a truly intelligent answer, but I can provide a common sense answer. So I think the majority of practices are looking at third party as delayed potential for pregnancy. And if you're using donor egg, you don't have the same time frame as someone that's doing autologous treatment. So I don't know of any, it doesn't mean they're not, but I don't know of any centers that have resumed care for third-party services. And I do appreciate that we could continue in some way to screen and match our donors. Again, I don't know centers that are starting to do that. We know that the longer a donor is on hold, whether you have an in-house agency or an agency that you're collaborating with, the more likely that that donor won't be available. So the question then comes is, in the next waves of patients that we allow in the doors, do we allow forms of egg freezing for donors, or do we allow creation of embryos and for later use for recipients? And I think that those are questions that practices have to ask themselves individually. But I think the focus is right now, who is the least prognosis patients in your centers. And I would challenge all centers to say our third-party prognosis patients are the highest in all of our centers. So I think that the initial ramp up is probably focusing on who can't wait to get pregnant.
And also, to add even more complexity, as if COVID-19 isn't complex enough, courts are closed.
Yeah.
Passport agencies are closed. The entire reproductive law community has been working very, very hard to try and get intended parents into hospitals when their gestational carriers deliver. There is a complete legal layer that adds to when we can get our patients back in third party. And, you know, for those of you still listening, we're actually working with some of the legal community to try and put together a webinar and how to deal with all of these legal complexities added to the clinical complexities of third party. I have a big concern. We don't want our patients to feel they're discriminated against. And as Sue brought up, it's going to happen, but how do we minimize that? By keeping them engaged. And as Sue said, there's a lot we can still do with our third party to get them queued up. And we also need input from the lawyers to help us figure out all of the, you know, factors that are going to maybe be stumbling blocks, and or maybe we've got new doors we have to open in order to make it work for them. So stay tuned for more information on that.
Great question.
Another similar set of questions. Lisa, well, I'm doing these. Can you put the slide back up with everybody's email address? Because some people are asking for your guys' email address, please. Thank you. So now, you know, we don't know what the effects of Clomid.
That one we know.
We do know about Clomid. We don't know the effects of COVID on first trimester pregnancy exposure, right? It's going to take a while. So the question is, are centers considering freezing all embryos up front instead of fresh transfers in light of not having a lot of info on the effects of COVID? So let's say that we have these consent forms, and part of the consent form that Lisa said is saying what we don't know. I guess the question is, are we going to still consider putting embryos back when in the center in May, or would we just focus a month on making eggs and embryos?
Lisa, if I can jump in, because
yes, please.
I do think, again, that's a practice decision, and we've seen practices all over the country doing different things. And as long as you have the rationale, it's important that you have that communication with the patient. This is a treatment decision based on the discussion between the patient and the physician. We know that some centers are doing low-tech transfers, such as frozen embryo transfers and IUIs, allowing patients to get pregnant because it reduces that patient's risk of going into the healthcare system for emergency care. So the concern about doing retrievals are 3% of our patients end up hospitalized, 1% hyperstim, 0.5%, whatever your center statistics are. And I think that that's what geared these recommendations to stop procedures so that we aren't overusing critical supplies or sending patients to the hospital. So again, some centers are allowing pregnancy. The CDC nor does ACOG say patients can't get pregnant. Patients should not get pregnant, I should say. So I think, again, it's a practice decision what to do. I know many practices are choosing to create embryos for later when we have a clearer definition of what the effects in the first trimester are for patients, and maybe wait to transfer embryos until we can determine an immunity status for the patient. So I think those are good questions without a great answer. But I think as long as your practice can defend your position, meaning that you've had this discussion with the patient, they're aware of their risk, as Lisa so eloquently stated, you've protected yourself by consenting the patient so that they know, then you're making the best decision that you can for your practice.
I just want to make sure that the blanks are filled out on the consent forms, because IVF, or the reasons that you went to IVF, put you at higher risk for ectopic, right? So then I don't know if we're connecting or linking that to, if you have an ectopic in the midst of COVID, your care potentially, arguably or unarguably, will be different. So it's not even just the getting pregnant, but it's the managing the risks of that. And so I guess the IVF consent that says you might be at more risk for ectopic really needs to be on the COVID consent, maybe. I don't know.
Well, I don't think it needs to be on the COVID consent, because we're going to end up with 25 pages again. And the patients already have an unbelievable amount that they have to deal with right now. With language that I use, I always include you're going to be signing other paperwork. So like Zika, like, you know, some of the other paperwork that we have our patients sign, it's always in addition to. So you look at the COVID information is in addition to any other information that we're going to give you. It doesn't negate that. It's on top of it. Does that make sense? And so I think it's a good question, but you know, I would never replace one for the other.
And it's important that your patients understand that by pursuing treatment, it could increase their interaction with healthcare. And although we're providing the safest COVID-free environments as possible, if your patient ends up in the emergency room or, heaven forbid, in the ICU, their risk is confounded by where they are. So the patients do need to understand that by pursuing treatment, even if it's low-tech IUI care, it could increase their probability of exposure through healthcare.
Right.
I think that's an important line to document, even though we kind of know that, to have it clear there. I think I answered everyone's questions that he emailed me directly. Is there anyone else that wants to write in the chat a question before we go? If I missed you, I apologize. Somebody wants me to re-put the polling results up, and I'm going to try to do that.
Okay. And if not, Monica, I know we've taken up a lot of time for people. Maybe we can include that on the, you know, tail end of our recording so that maybe they can get that. We'll figure, I know, we got to figure out how to do it, but yeah, maybe we can do screenshots or something and tag them on.
Yeah.
What do you think? Okay.
Yes.
Thank you.
And we're going to put this on the NPG message board once we edit it. So there'll be the emails everyone gave me will be in that email list, the NPG message board, my social media sites if you got them from LinkedIn or wherever. And then you can email us directly on that email side if you want something, we'll send it to you then.
Perfect. Thank you, everyone. Good luck as you work through this and as we're getting through our waiting period, and anything Sue or I or Monica or Mary can do to help, please let us know. Take care and stay safe.
Take care.
Bye-bye.
Bye-bye.